I'm going to talk about the performance of a few measures, just so you have a sense of how the measures perform. So on the screen, we are seeing the antidepressant medication management measure. This is a long-standing measure that has been reported by Medicare, Medicaid, and commercial product lines. The measure here is about medication use during the acute and the continuation phase of treatment. Acute phase is 8 weeks, and the continuation phase is 6 months. So as you can see, across the product lines, across the acute and the continuation phase indicators, the performance rate ranged from 40% to 70%. So there's definitely wide variation across product lines. And the acute phase indicator tended to have higher rates than the continuation phase. That just means patients are on the medications for a shorter time period. So definitely the performance indicated room for improvement. So this is another long-standing measure, but for the child population. So that's the follow-up after ADHD medication prescription. So on the screen, we have the initiation of ADD follow-up care, which means that children who are dispensed ADHD medication are having a follow-up visit within 30 days with the provider with prescribing authority. So we can see again here across 3 product lines, the performance rate ranged from 30 to 45%. This again indicates room for improvement. We know the audience have been engaged in quality improvement effort, and we know there are a lot of challenges in improving mental health and substance use measure performance. So the challenges range from a lack of providers to fragmentations in service delivery and payment arrangements. You all know NCQA's work in measure development and implementation, but it's less known, but we also conduct quality improvement work with states, health plans, and providers, typically through contracts. So today, I will provide an example of NCQA's project in improving the unhealthy alcohol use care. So the example is about improving unhealthy alcohol use care. We have a HEDIS measure on unhealthy alcohol use screening and follow-up. You heard Lauren describing it. So we convened a learning collaborative with 4 health plans to focus on reporting and improving performance of this measure. This is a 3-year project funded by the CDC and the SAMHSA, 2 federal agencies. We are in the 2nd year now and have been, so on the right-hand side of the slide, we have why we need this project. This is because we saw wide variation in performance rates on unhealthy alcohol use screening and follow-up for those who are screened positive. We also know there is a lack of consistent documentation of services. So for performance measure reporting, we rely on data that's documented in the health records or claims. So we also saw variation in use of standardized or validated screening tools for alcohol, such as Audit-C, and NCQA single question. So we learned all of these through our testing of the HEDIS measures a few years ago. So based on that, we wanted to conduct a quality improvement project that's back into the left-hand side of the slide, this learning collaborative. So NCQA and health plans each play different roles in this collaborative. So NCQA's role really is to provide expertise on measure specification and reporting the measure using electronic clinical data systems. So this measure is different from typical HEDIS measures, which mostly use claims data. This measure really relies on the electronic data such as EHRs, registries, case management systems, to find the screening tools used as well as the screening results, positive or negative. And health plans typically do not have access to such electronic clinical data. So that's part of the challenge and part of the focus of this learning collaborative is to leverage different data sources for reporting. So NCQA also provide approaches for quality improvement. Our staff is trained on the quality improvement models to guide and coach health plans. In this case, health plans also work with providers in their network to improve clinical flow and data flow. So this brings us to the lower left-hand side of a health plan's contribution in this project. They conduct quality improvement activities, report results to us, and engage in webinars that NCQA conducts. Health plans need to engage the practices and providers in their network to share data and improve clinical care. The plans also submit performance on this measure to NCQA 3 times a year. So the goal for this project, the Alcohol Learning Collaborative, are 3. Number 1 is to increase the use of structured electronic clinical data fields to facilitate sharing of information between plans and providers and measure reporting. This is where I mentioned the measure relies on clinical data. This is where the providers can really work with the plans to share information. The second goal is to increase the rate of screening. The third one is increase the rate of follow-up care for those who are screened positive. As I said, we are in the second year of this project. So we have, what progress have we made towards the goals? On the screen are the accomplishments so far. So these are mostly process-oriented accomplishments, which is not uncommon for a quality improvement project. So first of all, health plans have reported the measure rates to NCQA 3 times each year. We saw a slight improvement in performance in some plans and a slight decline in other plans. For the decline, we think it's due to more accurate interpretation of the measure requirements. So we also see health plans established relationships with providers to access EHR data. So EHR is a way to document the screening tools. There are codes in EHR to say which of the 3 required tools for screening is used, as well as the screening results. Health plans also provided provider education on the use of standardized tools and the coding terminology. The plans engaged with multiple stakeholders, including organizational leadership, the providers, data vendors, and the patient partners. We see some plans work with the data vendors to help them to report the measure. Others does the reporting in-house. The patient partners were identified by each plan. They review the materials and provide feedback to the health plans, mostly on how to engage patients and motivate them in screening and getting follow-up care. The last one is the plans, some plans use peer support specialists to help them to outreach to the patient that are screened positive. So a lot of efforts helping to move the needle to try to improve the unhealthy alcohol use care quality. So we also have lessons learned. So what have we learned through this project? So far, we have learned that health plans experienced barriers accessing electronic clinical data systems, the ECDS, and it reported a low rate at baseline. That was in 2017. We are working with health plans to figure out ways to collaborate with providers so that more information can be shared for reporting and quality improvement purpose. We also learned that misinterpretations of the 42 CFR Part 2 regulation hinders data sharing between providers and health plans. Many of you have heard of this regulation. Sometimes it's interpreted very conservatively, so organizations may not share information about alcohol or other substance use data. So to help to have a clear and accurate understanding of the regulation, we held a webinar late last year to explain the 42 CFR Part 2 regulation. We had guest speakers delivered that webinar. They are the healthcare lawyers. They are actually contractors to SAMHSA to provide technical assistance related to this regulation. So that was helpful to help the plans to have a consistent message when they communicate with providers as well as legal personnel within the plans and in the provider organizations. We also learned that standardized screening tools are rarely used, again, with these 4 plans and the providers in their network. We found those 3 tools are not commonly used, but those are the validated tools, and those are the only tools can get credit for the measure. We also learned that primary care providers need support in conducting a screening brief intervention and referral to treatment. So a lot of primary care providers felt they need training on experts in order for them to feel comfortable to provide screening brief intervention. And they also want to make sure there are specialists available to refer patients to when some patients need more specialty care. So I mentioned this new kind of a HEDIS measure, that's alcohol measure. Lauren also mentioned a few, the depression measures, for instance. They are based on electronic clinical data systems. So this is a new domain for HEDIS measures. We are moving more HEDIS measures into this type of reporting. So on the right-hand side of the screen, you see the different data sources. These are the typical electronic data systems, EHR, HIE, case management system, and administrative claims. So for this alcohol learning collaborative, it is about a measure that has to use this type of data sources. So you see claims data are listed here, but claims can only meet the follow-up rate, but cannot meet the screening rate because claims do not indicate exact screening tools or screening results. So the screening rate has to come from the first 3 type of data sources. So what can providers do? I know many of you in the audience are providers. We did find that providers can play important roles in working with health plans to improve clinical flow and data flow. Here are some examples of specific roles providers can play. For instance, providers can use standardized tools for depression, alcohol screening, because we have depression ECDS measures too. And also providers can share EHR data with state health information exchange and health plans for care coordination, quality improvement, and reporting. We know some health plans work with state HIE to be more efficient in measure reporting. We also know providers feed information into state HIEs. So that's another way for the healthcare organizations across the accountability levels to use available sources for quality reporting improvement as well as care coordination. We also learned that integration of primary and behavioral healthcare can help to improve these preventive care measures like depression screening and alcohol use screening.